Okay, let's jump right in. Today, we're taking a seriously dense 40-page lexicon monograph and distilling the whole shebang down into a highly focused, practical clinical masterclass on a true cornerstone of cardiovascular care, metoprolol. Whether you're a seasoned attending, a resident currently grinding on the wars, or a clinical pharmacist, this explainer is really designed to sharpen your prescribing practices. We're going to give you those high-yield clinical pearls you can actually use on your very next shift. Because let's be honest, it's a drug we literally see every single day. It's one of the most prescribed beta blockers on the planet. But here's the critical question we have to ask ourselves. Are you absolutely sure you're dosing it correctly? Like, are you confident in your oral to IV conversions? Do you know exactly how it behaves when a patient's liver function starts declining, or say when they're relying on a feeding tube? Today, we're going to challenge a few assumptions and really refine our understanding of this everyday drug.
So, here's our quick roadmap for today. We'll be looking at 1. Mechanism of action. 2. Clinical indications. 3. Formulations and dosing. 4. Administration guidelines. And finally, 5. Warnings and adverse reactions.
All right, let's start with Section 1, Mechanism of Action at the cellular level.
So fundamentally, metoprolol is a cardioselective beta-1 adrenergic blocker. Basically, that means it competitively blocks the beta-1 receptors found primarily right there in the heart, which slows the heart rate and reduces myocardial contractility. But here is the absolute crucial pearl to remember, that cardioselectivity, it's dose-dependent. At adult oral doses under 100 milligrams, it's great. It leaves the beta-2 receptors in the lungs and vasculature largely alone. But as soon as you push that dose higher, well, that selectivity diminishes and you start getting beta-2 blockade. It's a foundational concept, and it absolutely dictates our safety monitoring later on.
Okay, moving right along to Section 2, Clinical Indications in Patient Care.
Now, we all know it's FDA approved for the classics: chronic stable angina, hypertension, heart failure. But what's really fascinating is its massive utility in off-label arenas. I mean, beyond those standard uses, metoprolol is an incredibly versatile tool. We're talking powerful, evidence-based applications for migraine prevention. We rely on it heavily for acute ventricular rate control and atrial fibrillation and flutter. Or what about hemodynamically stable patients with supraventricular tachycardia when vagal maneuvers just aren't cutting it? We even use it to wrangle the dangerous cardiovascular effects of thyrotoxicosis until the patient reaches a euthyroid state, and for preventing ventricular arrhythmias. It is, quite literally, an absolute workhorse.
Next up, Section 3, Formulations and Dosing, Avoiding Errors.
Okay, you really have to know the difference between the two main salts here: tartrate and succinate. Metoprolol tartrate, that's your immediate release formulation. It has a shorter half-life and requires divided dosing, so usually twice a day. We use tartrate in acute, fast-moving settings like early myocardial infarction treatment or acute rate control. On the flip side, you have metoprolol succinate. This is your extended release formulation. It's designed specifically for chronic, once-daily adherence. And remember, succinate is the specific formulation proven to actually reduce mortality in heart failure with reduced ejection fraction. You absolutely cannot just swap them one for one without adjusting that dosing frequency.
And that brings us to the hard ceiling of our dosing: 400 milligrams. Whether you're using tartrate or succinate, 400 milligrams per day is the absolute maximum daily dose when you're treating conditions like chronic stable angina or maintaining rate control in SVT. Honestly, pushing beyond this rarely gives you any significant clinical benefit, and it dramatically increases the risk of losing that beta-1 selectivity we just talked about. Now, let's contrast the routes of administration, because this sets up one of our most absolutely critical safety warnings. Metoprolol goes through extensive hepatic metabolism. When you give it orally, it has a massive first-pass effect. We're talking about 50% of the drug being metabolized by the liver before it ever even sees the systemic circulation. But when you push it intravenously, it enters the systemic circulation directly. It completely bypasses that initial hepatic breakdown. So what's critical to remember here is this exact ratio: 2.5 to 1. Because of that heavy first-pass metabolism, this is your standard conversion ratio from oral to IV dosing. An oral dose is roughly 2.5 times larger than the equivalent IV dose. So say you have a patient taking 50 milligrams of oral metoprolol daily, while their equivalent IV dose is just 20 milligrams daily, divided into smaller doses, like 5 milligrams every 6 hours. If you accidentally, say, prescribe the oral dose amount via the IV route, you are risking a massive, potentially fatal overdose. Always, always do the math. Speaking of the liver, because metoprolol is so heavily metabolized by hepatic enzymes, specifically CYP2D6, You have to adjust your initial dosing for patients with cirrhosis. We use the Child-Turcotte-Pugh classification for this. For Class A, mild impairment, you're good. No adjustment needed. But for Class B, you've got to cut your starting dose by 50%. And for severe Class C impairment, you really should avoid it altogether if possible, or start at a mere 25% of the standard dose. Oh, and one more thing. You should definitely use the immediate release tartrate for initial dosing in these patients, not the extended release. All right, let's take this to the bedside. Section 4, Administration, Bedside Guidelines. For patients relying on gastric feeding tubes, administration requires some real precision to ensure bioavailability and, keep from clogging the hardware. If you're using extended release sprinkle capsules, you have to follow this exact 5-step sequence. First, hold the enteral nutrition. Second, flush the tube with 15 milliliters of purified water. Third, administer the dispersed medication via an enteral syringe. Fourth, carefully flush the syringe and tube again with another 15 milliliters of water. You want to make sure no pellets are left behind. And finally, restart the enteral nutrition. Now, the crucial point here, and I literally cannot emphasize this enough, is regarding the standard extended-release tablets. Enteral feeding tube administration of Metoprolol extended-release tablets is strictly not recommended. You must never ever crush these ER tablets. Crushing a modified-release tablet totally destroys its delivery mechanism, and that causes immediate excessive dose dumping. This leads to wildly variable serum concentrations and risks severe, potentially even fatal adverse cardiovascular effects. Just don't do it.
Okay, Section 5, Warnings and Reactions. High Alert Protocols.
Let me ask you this. What actually happens if a patient who has been on chronic metoprolol therapy just stops taking it cold turkey?
Well, the answer is a highly dangerous physiological rebound. When you continuously block beta receptors, the body responds by upregulating them, basically increasing their sensitivity. So if you abruptly withdraw the drug, you unleash this massive transient sympathetic hyperresponse. This catecholamine surge peaks within 48 hours and can cause acute tachycardia, severe rebound hypertension, transient ischemia, angina exacerbation, and it can even trigger a myocardial infarction in patients with underlying coronary artery disease. You absolutely must always taper this medication gradually over 1 to 2 weeks.
When you're monitoring a patient on active therapy, it helps to think in threes. The top 3 adverse reaction categories you want to watch out for are, number 1, bradyarrhythmias. We're talking sinus pauses or varying degrees of AV block, since we're slowing conduction right through the AV node. Number 2, bronchospasm. Remember that diminished cardioselectivity at higher doses we discussed? Even at normal doses, the risk still exists, so keep a really close eye on your COPD and asthma patients. And number 3, CNF effects. Metoprolol is moderately lipophilic, which means it crosses the blood-brain barrier. That can cause fatigue, insomnia, and notably, some incredibly vivid nightmares.
We also have to talk about our diabetic patients for a second. Metoprolol inhibits hepatic gluconeogenesis and actually blunts the normal sympathetic nervous system response to low blood sugar. Practically, this means it actively masks the standard warning signs of hypoglycemia, like tremors, irritability, and palpitations. For a diabetic patient on metoprolol, diaphoresis, or sudden unexplainable sweating, is very often their only reliable physical clue that their blood sugar is crashing. You have to educate your patients about this altered warning system.
I want to leave you with one final kind of provocative clinical thought. As bariatric surgeries become more and more common, we really have to consider pharmacokinetics. These procedures drastically alter GI transit and absorption in ways that are highly unpredictable. The studies actually show really wide interpatient variability in metoprolol exposure following bariatric surgery. So when that post-op patient walks into your clinic, ask yourself, are they really absorbing the dose you prescribed, or are they maybe experiencing hidden hypotension or uncontrolled tachycardia? It's a powerful reminder to never just set it and forget it. Always reassess the changing physiological needs of your patient. Thank you so much for joining me for this explainer, and I'll see you next time.